Well, thank you very much, Alice, for inviting me to give a talk today. So I'm going to talk about the development of a combined digital and biomarker test for bipolar disorder. I'm going to talk a little bit about the clinical implications as well, and also then the biomarker applications. So first of all, I want to just point out how prevalent mood disorders are. In particular, depression. About 6% of the population will have a diagnosis of major depressive disorder during their lifetime. This is about 1.9 million people who present with depressive symptoms to their GPs each year in the UK, and on average 25 million in Europe. And 10 to 20% of these patients who present with depressive symptoms actually suffer from bipolar disorder. I will explain a little bit more what bipolar disorder is. So bipolar disorder develops often in late adolescence, early adulthood, and most cases present with symptoms before the age of 25. But unfortunately, it takes 7 years or longer for most patients until they're accurately diagnosed. And we will talk a little bit more about why this is in the successive slides. One of the problems is that patients who suffer from a mood disorder initially present to their primary physician, to their GP. And they only have on average 5 to 7 minutes to talk to a patient to come to a diagnosis. And this is why they often miss symptoms of bipolar disorder. And therefore, 60% of patients are initially misdiagnosed, 40% are misdiagnosed with major depression, so with a depressive disorder where people only have episodes of low mood, and they miss that the patient may have had already manic episodes or hypomanic episodes, which are the key feature of bipolar disorder. The high rate of misdiagnosis is associated with higher rate of morbidity, increased hospitalizations with manic episodes, mood cycling, and indeed suicide. Bipolar disorder has a high concordance rate amongst identical twins, so has a high genetic component, which is attributed to about 80%. So here a little bit more about bipolar disorder. So bipolar disorder affects about 1 in 3 people in 100, 1% to 3%. It's characterized by extreme mood swings. This is for bipolar disorder 1. So we have to differentiate bipolar 1, where there are severe changes in mood, particularly manic episodes, which are typical ideas of grandiosity, people believing they have special powers. People can't sleep at all, severe insomnia, increased activity, patients talking non-stop. They can't, their thoughts are racing, they are very distractible, they're irritable. They can often overspend money that they don't have, and sometimes they also present with psychotic symptoms. So, and as you can see here in the orange line, this is bipolar disorder 1, which is where patients present also with manic episodes and also with episodes of low mood. And the blue one is major depression, where patients only feel low. If in the middle, there's normal mood. And you can see for bipolar 2 in green, they have mild elation in mood, which would not be recognizable to someone who doesn't know them. Only people who know them very well say, oh, feels a little bit hyper today, but it would not be obvious, and they may still be able to work normally, which is not the case if someone has a full-blown manic episode. And this is why it is so difficult to diagnose bipolar disorder. And also these graphs are quite misleading, because many patients with bipolar 2, for example, have 40 episodes of feeling low in mood and only 1 episode of hypomania. And also for bipolar 1, some bipolar 1 patients may have only 1 or 2 manic episodes in their whole lifetime, and the rest of the time they have low episodes. And also patients only go to their doctors when they feel low in mood and not when they're feeling good about themselves. So this is why the misdiagnosis is so prevalent. And the problem of misdiagnosis is that patients with bipolar disorder should not be treated straight with an antidepressant. They need to be treated with a mood stabilizing drug, which is classically been lithium, but also anticonvulsants. And they often don't respond to antidepressants if you just prescribe antidepressant because a doctor only identifies the episode of low mood and misdiagnoses them as major depression. And antidepressants can also induce a manic episode. So a doctor in this case with a misdiagnosis can still cause obvious harm to patients. So it's very, very important to find the right diagnosis, because if patients don't get the right treatment, they may not get better for a long, long time. And and as I just said, it's on average 7 years until patients get the correct diagnosis. So this is causing a hell of a lot of harm. The problem here is obviously the overlapping symptoms, and what as I just said, patients seek help when they're depressed and not when they're feeling good about themselves. So what we did in 2018, this was over 6-month period, we started Delta study, which was also with a follow-up at 6 and 12 months, which I'm going to report upon. So the aim was to develop a diagnostic algorithm based on a digital questionnaire and blood biomarker data to identify patients with bipolar disorder, especially patients who have previously been diagnosed with major depressive disorder, who we believe have a bipolar disorder diagnosis, which is the correct diagnosis. So we combined a digital questionnaire. I'm going to give you more detail in a second, which was delivered digitally to the patients. Obviously, this was a non-linear questionnaire where we asked questions: have you been feeling low in mood? And then asking all the depression questions. And only if they say that they had some symptoms of low mood would we go into more details about current and past symptoms. And patients who fulfilled eligibility criteria were also sent a blood spot collection kit. And we had a video online and clear instructions, and all the components CE marked in a little collection box. And there they could pick on their finger, they could draw blood, put them onto dry blood spot filters, dry them down, and send them by normal post to us for analysis. So the online mental health questionnaire was a purpose-built platform based on DSM-5. This is the Diagnostic Manual for Psychiatric Disorders, which is currently used to diagnose patients by a psychiatrist. And it emulates a full psychiatric assessment and really also collects holistic information about patient social circumstances, traumatic experiences. And we're also asking about drug and alcohol use, about many other symptoms like anxiety, like obsessive compulsive disorder, eating disorder. So it's holistic and really assessing the majority of the spectrum of psychiatric conditions, because all of those are relevant to a correct diagnosis. So it was a total of 635 adaptive questionnaires. It was adaptive as it only asked, there were screening questions at the beginning, and only if patients were positive on these would it go into the tree of further questions. So an average study participant answered 283 questions, and it took them about 46 minutes to complete the questionnaire. And this was focused on demographics, about psychiatric history, manic, hypomanic symptoms, depressive symptoms, comorbid psychiatric symptoms, as I just mentioned, and also a personality assessment. And the endpoints, what we tried to achieve was to identify those patients with bipolar disorder who have previously been diagnosed with major depressive disorder within the last 5 years, and also to identify patients with major depressive disorder and bipolar disorder in symptomatic help seekers without the previous psychiatric diagnosis. So we did a power calculation, and we needed about 40 previously diagnosed patients with bipolar disorder, 400 patients with a diagnosis of major depressive disorder within the last 5 years, and 400 patients with low mood, presenting with symptoms of low mood, but no previous psychiatric diagnosis. And this is how the study design flows. We did all eligibility and consent online. We then delivered the digital questionnaire, and then selected those patients who fulfilled inclusion criteria. We sent them the dry blood spot collection kit. And then we trained 10 ladies who were trained to deliver the structured clinical interview, which is a platform developed by the World Health Organization, which has good accuracy to diagnose both depression and bipolar disorder. And then we had the 6 and 12-month follow-up. So we advertised through Facebook Club website and email, and these were the inclusion criteria for our study. So patients were not supposed to be currently suicidal, and they had to present with symptoms of low mood. So this is represented by PHQ-9, which is a rating scale for depression of a score of above 5. And we limited the age range to 45 because we didn't want to have patients with a lot of physical health problems adding to complexity when looking for biomarkers when there are more chronic health problems that could have been problematic. So this is the CD, the Structured Clinical Interview, World Health Organization, World Mental Health, Composite International Diagnostic Interview. It's a comprehensive, fully structured interview, can be delivered by lay people. So these 10 ladies who we trained did all these interviews in a systematic fashion. And these were the successes of the Delta study. During the period of 6 months of recruitment, we had 40,000 visitors to our trial site, 5,000 participants recruited. We sometimes had to close down the website because there was such interest. We were able to collect almost 1,400 white blood spots from patients, conducted almost 1,000 CD interviews online, and delivered reports. So these are reports back to patients about they had to be quite vague about, your symptoms indicate that you may be suffering from bipolar disorder or that you may be suffering from a major depressive disorder. And patients could then take that report to their doctors and ask for a referral to a psychiatrist. So we had positive patient feedback as well, which I will talk about when I talk about the feedback as well at the 6 months and 12 month follow-up points. So these were the objectives again at the 6 and 12 months, was to look at the impact and quality of life for participants, particularly measuring the Warwick-Edinburgh mental well-being scale. This is measuring how good is someone feeling about themselves, how they're coping with stresses in life. And we wanted to see whether the assessment had an impact on their general well-being. We also asked them, had they, as based on the previous assessment and report they received, had they seen a psychiatrist or a doctor and had their diagnosis been changed? And we also asked whether their medication has changed as a consequence of doing the digital assessment. So these are the results. So when we looked at the digital assessment, we had already a very good accuracy of the test. So the digital only gave for bipolar 1 and 2 together an excellent performance. This is area under the curve, which is how good a test is, or anything above 0.9 is an excellent performance. Something around 0.8 is a good performance. So we are amongst a good and excellent levels for BD2, which is a little bit more difficult to diagnose. We have an accuracy of 0.88. So this is what our digital assessment does in comparison to the CD diagnostic assessment by which we independently evaluated, and we looked at how good they matched. So there was a good concordance amongst the CD and our new assessment platform. But we were also interested in biomarkers for the condition, because we know that if patients don't give you the symptoms of having been manic in the past or hypomanic, then it is very, very difficult to come to the right diagnosis. The patients who we recruited online were very motivated, and they gave us a lot of information, so we had a high accuracy. But if you're in the clinic, many patients are not so willing at coming forth with their past symptoms. So the diagnostic accuracy amongst psychiatrists of diagnosing a patient with bipolar disorder is not as high. It's probably around 0.6 area under the curve. So there is room for improvement. So this is why there's also a role for biomarkers to add. And also we've conducted studies amongst bipolar patients, and also the Bipolar UK, a charity, asked patients whether they would like to have a biological test for bipolar disorder, and over 90% said they would really appreciate if there was a biological test, because it would make it feel that they have a real illness, because mental illness is still associated with a severe stigma. And it seems all in their mind. And many patients feel that if there is a biological correlate which indicates that they have an illness, that would be very, very helpful to them to accept the illness as well. So I think there is a big need to bring mental illness into the realm of physical illness, which it is indeed, similar to diabetes and other conditions. So we use the MXP Quant 500 platform, as Alice just outlined, 630 metabolites. And we cut out the 3mm discs in our labs, and we shipped them to biocrates, and they run our samples and send us the data. And Dr. Jakub Tomasik is the key data scientist who did all of this analysis. So we used data from 67 bipolar patients who were diagnosed by the CD with bipolar disorder against 174 patients with major depressive disorder, where this diagnosis was confirmed with the CD as well. And we trained them, and we achieved a good area under the curve of around 0.7, which is a fair diagnostic performance, but still very encouraging. We only had a few samples left to do an independent validation. These are samples who at 1 year follow-up told us about a change in their diagnosis, and that those could be independently used to validate the findings. And we found a similar area under the curve here as well. So this was very encouraging. And the biomarkers which prominently sort of stood out, or one of them is ceramide, here a specific ceramide, D18. This stood really out as a key biomarker. And then we have other biomarkers which are related to neurotransmitter synthesis, kynurenine pathway, insulin-resistant energy metabolism. But this ceramide is very promising and interesting because it's associated with myelination and has also been implicated in Alzheimer's disease and other neurodegenerative disorders. So we also found that the biomarkers, in particular the ceramide, correlated with symptoms of mania, which was very interesting. So a potential surrogate marker of manic episodes, again, very helpful if the biomarker is going to be used for diagnostic purposes. And we found that although the digital questionnaire was very good in itself, the biomarkers for most patients' information, if we added the biomarkers, it increased the performance. So with the biomarker test, we believe we could diagnose an extra 30% of patients. And in 2024, we did an independent validation study. We recruited another cohort of patients, several hundred patients. And here we included 143 bipolar patients diagnosed with an algorithm previously on the previously built platform, and also 240 major depression patients. And here we have the initial cohort, which was the cohort which I reported on previously. This was an errand curve of 0.71. We had the validation cohort from 2024, and this here is the combined cohort, sorry. And here the area under the curve went up to 0.75, which is quite reasonable. And importantly, the ceramide remained the top biomarker, and we are very excited about that, and we hope to bring this to the clinic. So the combined digital and biomarker test now gives an area under the curve of above 0.94, which really is very good. But I also want to point out the other benefits of clinical benefits of doing the digital assessment. So at the 1 year follow-up, we asked patients how useful they found contributing to the Delta study and how they believe this related to their mental health outcomes. And we found that a large percentage of patients said they were talking more openly about their symptoms because they felt encouraged by doing the assessment to talk about their symptoms with friends and family, and that helped them also then to open up and seek help. They felt they understood their problems better, and they were more proactive at help seeking because they got this tentative diagnosis. So it was quite amazing how this little report that we sent to them with some psychoeducation was so helpful. And they found particularly helpful the results that they received, the psychoeducation and so forth. And we could also see that quite a lot of patients changed their diagnosis. So they then saw a psychiatrist, and then based on their report that we sent them, and their diagnosis was changed. And what was amazing was also at here 6-month and 12-month follow-up, we see a significant improvement in their overall mental health as assessed by a well-being screen. So they report that they here sort of they were more proactive help seeking. They felt the diagnosis was very helpful in shifting basically their well-being, their personal circumstances. They were exercising more. So it's amazing that patients find such an improvement with very little input of this assessment. This was the same effect size as a psychotherapeutic treatment over 12 sessions would have probably had. So this is the reported effect size of other psychological interventions. You can see a similar response rate. And furthermore, the digital assessment was now moved into the clinic. So we are using the digital assessment to generate a report of patient symptoms, and doctors and nurses are using that in treating patients. This is now used in many NHS trusts already, and we hope to add the biomarkers to these platforms as well, because particularly in primary care, where doctors don't have the time to do the full assessment and may not be as knowledgeable, a digital plus a biomarker combined test could be very, very helpful. I will not go into too much detail. There are obviously great challenges, particularly in the UK National Health Service, will not go into that. And a combined digital and biomarker test will have lots of impact. And we saw that as well, even the digital alone. A digital assessment reduced referral rates here in this is Hertfordshire Mental Health Trust. We improvement in 28-day target adherence. So this is meeting national targets of treatments and intervention. It increased operational efficiency by around 1/3 and reduced variability, because many patients who come into the system see different physicians and often get different diagnoses at different contact points. So there was a very positive feedback about the platform. Also in another NHS trust, they found they could reduce the repeated assessments by 67%. So obviously this has also significant cost implications. Thank you very much.